Okay, so thank you for joining us today. I know we're a small group, but hopefully you can take away a lot from the presentation. I have briefly talked about our toolbox before when I presented with Nick Joachimides a couple months ago. It was only about 5 minutes, so today we've had some exciting updates and we're really excited to share them with you.
So my name is Tierna Rava. I'm a knowledge translation specialist with Evidence to Care here at Holland Bloorview. And I'm joined today with Ashley.
So as I said, I'm a knowledge broker here with Evidence to Care, and we both help to translate scientific evidence every day into clinical practice at the hospital. Our project today also wouldn't be possible without our many partners, and we just wanted to give them a brief shout out to say thank you for all their expertise.
So today's brief presentation has 3 main objectives. The first is to explain the concern of chronic pain for children with disabilities. The second is to outline the contents of our chronic pain toolbox. And the third is to describe the knowledge translation supports for implementation and evaluation. So before getting started, we just wanted to provide you with some context regarding where the toolbox has been implemented. So Holland Bloorview Kids Rehab Hospital is Canada's largest pediatric rehab hospital, which strives to create a world of possibility for children with disabilities. So Bloorview is a teaching hospital fully affiliated with U of T, which also is supported through our on-site Bloorview Research Institute. A unique aspect of Bloorview is our Teaching and Learning Institute, which supports our staff and the next generation of health professionals. Evidence to Care at Holland Bloorview is embedded within both the Bloorview Research Institute and the Teaching and Learning Institute. So ETC, as we refer to it, bridges the gap between research, evidence, and clinical practice. And we partake in traditional knowledge translation activities aimed at bringing the right information in the right format to the right people at the right time to have an impact on decision making. We're an organizational catalyst for knowledge translation, and we're kind of the go-to source for systematic reviews, clinical practice guidelines, and evidence-informed best practices. Evidence to Care aligns its project with the knowledge to action cycle. And this cycle has 2 main components. So in the center we have the knowledge funnel, and that's intended to bring a broad range of research evidence through multiple syntheses to customize evidence to meet the needs of an identified problem. And then we have the action cycle, which is the perimeter, and it's the process where the knowledge that is created is implemented, evaluated, and sustained in the practice setting. And we use this K2A cycle to develop our toolbox. So after chronic pain was identified as an area for concern in our outpatient child development programs, we then created the toolbox. Prior to telling you about the content, let's kind of orient to the problem of chronic pain. So this project was initiated from a call for projects by ETC in 2012. So our clinicians identified that chronic pain was a concern for children with disabilities, especially for children with cerebral palsy or CP. Children with disabilities are more likely to experience chronic pain compared to typically developing children. And as shown in this cycle on the right, pain has a significant cascading effect on the mental, physical, and social well-being of a child, which actually causes further pain and impedes on daily living activities. Current systematic reviews on pediatric assessment tools have excluded children with disabilities, so there is a need to identify tools that could be used with children with communication, cognition, or mobility impairment. Therefore, the Chronic Pain Toolbox for children with disabilities was formed. So to create the toolbox, a structured review of clinical practice guidelines was conducted, and retrieved guidelines were taken through the Agree-To tool. Now, this is a process used to assess the quality of clinical practice guidelines. Clinical practice points were developed alongside our clinical partners to guide the assessment of chronic pain for children with physical disabilities. Evidence to Care conducted a systematic review of the pediatric chronic pain assessment tool literature, and the retrieved tools were brought to our interprofessional working group, who you saw listed at the beginning of this presentation, who through a consensus activity critiqued and select high-quality tools for inclusion in our toolbox. So the toolbox, which is available for download on our website, includes a background document outlining our methodology, the clinical practice points, 15 pediatric chronic pain assessment tools, 7 of which focus on chronic pain interference, and 8 which focus on chronic pain coping, and an implementation supports manual, guides users from external organizations through the K2A cycle and provides tangible resources developed by ETC specifically to this project. So now that you've heard a bit about the background, I'm going to pass it over to Ashley to review how the toolbox was put into action at Holland Bloorview.
Thanks, Karen. So at Holland Bloorview, we knew that our context was unique. Not many products have been built specifically for children with disabilities, and we recognized that we needed to center the toolbox within the culture and flow of our clinics. We worked initially with 3 outpatient pilot clinics that see a high volume of children with cerebral palsy, and we worked with them intensely for 6 months to put the toolbox in place. It was decided to start with this smaller, more manageable pilot group to test and modify this product before rolling it out further. With the 15 pain tools, we had the pain recommendations and practice points as well, and it was a lot of information to implement at one time. So we met individually with the pilot clinics to review the 15 tools. We looked at the questions, the length, scoring, and fit of the tools for implementation. Ultimately, we landed on 4 common tools across all 3 pilot clinics, 1 of which was used for children who were nonverbal. 2 tools assessed the impact of pain on function, and we had 1 body diagram. From a review of the KT literature and in our experience at the hospital, a new intervention needs supports to be implemented consistently. Evidence to Care used a number of integrated KT strategies to facilitate the implementation of the toolbox into practice, which included an education campaign, pain champions in clinic, huddles, audit and feedback techniques to evaluate practice change, and the phase that we're in now, sustainability planning, to ensure that this product lives beyond its pilot phase. First, I'll just discuss a bit about the education campaign. We decided to conduct an education campaign because we didn't want to make assumptions, and we wanted to ensure that everyone was working from the same base knowledge around pain. All these sessions were facilitated in face-to-face meetings. We worked with our manager of patient safety, who had a well-developed background in pain, to provide education. And you guys might know him. His name is Nick Joachimides. He works here at Holland Bloorview. Well, not anymore, actually. He's moved on to Bridgepoint, which we're very sad about. But he initially helped us with the campaign to go over an overview about types of pain, pain in children with disabilities, and the current status of pain assessment at our hospital. Then Evidence to Care stepped in and we provided information specifically on the toolbox contents, like how to use the tools, how to score them, and how to document them. Next, I'll discuss a bit about our huddles. To support implementation in clinic, we employed this strategy where we met on a weekly basis for 15-minute touchpoint meetings in the clinical area. This served as a way to hear the chit-chat around the water cooler, a way to share successes, address any barriers and challenges as they came up. It was also a way for clinicians to solve challenges among themselves or for Evidence to Care to address it behind the scenes. Eventually, we ended up tapering off the huddles from once a week to bi-weekly and then not at all, as the pilot clinics got more comfortable with using the toolbox. We took minutes, we sent them out weekly to inform the clinicians that could not attend, and this also kept everybody accountable to the action items. To support implementation and documentation, we looked to our electronic medical record. We worked with the pilot clinicians to modify an existing pain screen to document pain assessment practice, including all types of pain like acute, chronic, environmental, and phantom limb. They could also record the pain tool scores and any intervention recommendations that they made. This also supported our evaluation needs. And then what we did is we took the information that we gathered from the screen on a monthly basis, and we fed these stats back to the pilot clinicians in the form of a flow chart, which you'll see on the screen. And this was to inform the clinicians about the uptake so they know where the project was standing. So it's been over a year since we started the project, and at this point we've been able to engage another 5 clinics to repeat this implementation. So right now we're in a total of 8 clinics at the hospital. We're looking for ways to build this project into the system by moving it from a pilot project to a standard of practice, or just how things are done around here. In the upcoming year, Evidence to Care will continue to provide supports for our clinicians, but we will also shift the responsibility to system champions, or people we can identify as being the, quote, go-to person within each discipline for pain assessment questions. In addition, we'll refine the clinician support, such as the electronic medical record chronic pain screen, and make the tools accessible in the most convenient way for our clinicians. We will ensure that this is an evidence and clinician-informed process by conducting consensus activities with key stakeholders and a review of our data to make the necessary changes. We've made our toolbox available externally so that your organizations can benefit from this work as well and implement it without a team like Evidence to Care in place. Social media outlets like Twitter and YouTube have been great resources to profile the Toolbox website and the issue of chronic pain for children with disabilities. We hope that you'll be able to check it out after the webinar. There's a place to enter your name and email, and we're hoping to contact those who have downloaded the Toolbox for a short evaluation. In conclusion, the Toolbox is valuable by providing a standardized way to assess chronic pain in children with physical disabilities. Through our internal evaluations, one clinician has said that the Toolbox allows us to gather information more systematically and to ensure that it happens for every client in the same thorough way. We'd like to thank our supporting partners, the Holland Bloorview Foundation, Ministry of Health and Long-Term Care, and the Registered Nurses Association of Ontario for their support of this project. So that's the end of our presentation, and is there anyone that has any questions for us? Hello?
Ashley?
No questions here. That sounds great.
Okay, fantastic.
Actually, Ashley, it's Elaine. I do have a question.
For sure.
It's a question and comment. First of all, just a fantastic presentation. And I guess I put this out to Samina and Janet and all of our COP members. In terms of lessons learned, to sort of go back to what you had said originally, Samina, I think, you know, the education campaign, the huddles, the audit and feedback, and then that external push activities, you know, using social media, etc. Those really, I think that is a really good lesson learned for us, or just something for us to think about in terms of how and when we're ready to implement our guidelines and, of course, the toolkit alongside.
Yeah, we found it really, really helpful. We made a video, if you go to YouTube for Holland Bloorview, they have a YouTube channel, and we made a video which has had fantastic viewing. Now, I mean, not quite as much as like Christine Chambers' video, but we're getting there. It just sort of, it was a great way to highlight the project and a great way for us to have the implementing clinicians really participate and contribute to the external push. Also, I would say if you can find people that have very high profiles on Twitter to tweet out the procedural pain information, that would be great, because like our CEO and our collaborative practice leaders have been fantastic at helping get this out there, and because they have so many followers, it was very easy for other people to find it.
Right. And just one more thing to add to that for the external push. It's very important to know who your target audience is and who those key players are. So in conjunction with sending out just broad things into the Twitterverse, so to speak, we also sent targeted letters to individuals who we knew in other organizations were interested in chronic pain. And not necessarily that we would need to be in pediatrics per se, but we really wanted to spread the message so then they would take that and push it out through their network. One quality that we have on our website is that we ask for the name, email, and organization, so we know who those partners are who are downloading it. So then we can send a follow-up survey later on and ask those questions like, how did you use the toolbox, or give us some feedback, and where else do you see this being used? So I think a really good lesson is in anticipation of finalizing the product is to really know who you want to use it.
Absolutely. Absolutely.
Okay. Are there any other questions, or?
Yeah, hi, this is Samina. Absolutely. I was just wanted to give everyone else an opportunity before I spoke. And so if there's no one else who has a pressing question, I would love you, certainly, Ashley, you've been involved with this community practice for quite a while now, and I suspect you may have filled in your colleague a little bit as to where we're at as well, Taryn as well. So my question to you two is, what would you say from what you learned from this incredible experience, and I would echo Elaine's comments, it's amazing what you guys have done here. How could we use this in our community of practice setting where we are reaching out to a much larger number of centers? So it's not dealing with 4 clinics. We're probably looking at, and Elaine, maybe you can speak to the number, but potentially a dozen, 2 dozen, 3 dozen centers?
Yeah, yeah, absolutely. I mean, we'd probably start off a little smaller than that, Samina, maybe like just as Ashley and Taryn have done as a pilot, but the numbers will be large in terms of the numbers of healthcare organizations. Yes.
Because I'm definitely hearing from you two that the one-on-one engagement, you're going in, doing these audits, facilitating these huddles is what helped affect change. How does that translate when I'm sitting in Edmonton and you're sitting in, where I was going to say in Holland, Bloorview, but I imagine there's a city, Toronto. And so how can we then reach out to our colleague in Yellowknife if none of us are there?
Absolutely, and I think that's where the position of a champion comes into play. Having someone either that was self-identified or perhaps someone at each center within each clinic who is that go-to person, who is really that content expert on your toolkit, then can answer any questions within their particular context. And then maybe some sort of reporting back system so everyone is receiving the same amount of information across the board, but then there's that one person that can tailor it to their particular context.
Okay, so that one person identifying our lead, local site lead, will be key to the successful use of this toolbox rather than it becoming something that collects virtual dust.
Exactly, and also I think it's good to have, we have the audit specific here because that's an indicator of use, but if you set indicators for external sites, then you would be able to ask for them to report something back to you so you're aware of how they are using it on a regular basis.
Okay.
And just to add to that, because you're working in probably large organizations in many different locations, in addition to the champion, it might be helpful to get the senior management endorsement from each of those organizations so that clinical champion does have buy-in from their organizations to support that role. And also I think management is going to have an easier time to say, yes, we're going to alter an electronic medical record screen. Yes, we're going to give nurses some release time to do a bit of education, even if it's like online education. So I see using both.
And yourselves as the leaders of this project, you can provide those benefits to the centers to say, here are a list of reasons why this will benefit your organization. And so they can then take that to their senior management for buy-in.
Samina, I don't want to break your sort of train of thought just in terms of various things you want to ask, but maybe just at this point a comment. I love where the conversation is going. I find it very exciting. I think from a virtual perspective, which is more, of course, where CAPHC's pain COP is coming from, but I think the concepts and the well, I'll say the concepts that Ashley and Taryn are sharing with us can be applied within a virtual. So that initial sharing of the toolkit from a knowledge translation education perspective, that can be done in and of course it takes organization and that sort of thing, but through webinars and sort of and we can make them video, so we're actually we're seeing each other and that sort of thing, and we can do that site by site. We can do that by bringing a few sites together. But then what I'm also hearing a little bit of train the trainer kind of concept as well. And then the liaison, you're finding that champion. CAPHC has a liaison at every one of our member organizations, and that's the person who translates CAPHC and brings CAPHC to the organization. And of course, and often they're referred to as champions. So I could see us implementing a very similar communication mechanism, a similar team, but of course it would be more virtual.
Okay. And perhaps what we can do, drawing on this experience of Taryn and Ashley's, is we create. I can see at some point we have to draw the line as a CAPHC of community practice and say, okay, we won't be doing these extensive knowledge translation activities like Holland Bloorview has done for every center, but perhaps we can draw on your expertise and experience and create some sort of summary for them to say, this worked at another center. We'd like to support you in doing this, so tell us what you need, but here are your steps. That would probably make this more effective than just emailing out this toolbox to your clinical staff.
Right.
And this is Ashley. Also, how you were mentioning starting with a smaller group before rolling it out to the broader audience. I mean, you might be able to provide more support to, say, an initial 5 centers that show a lot of interest and a lot of uptake of it, and then from there you can kind of remove the support and like you said, Samina, develop the one-pager or the lessons learned from those 5 centers and have it go broader with less support from there.
Right. I fear we've lost Shannon. I don't see her on our list of participants anymore. I don't know if she fell off the call. Shannon, are you still there?
I just saw Shannon sign off. Yeah, so perhaps she'll come back on, I hope. But, yeah.
Okay. And if she does, I was just going to ask her, she has quite a bit of experience doing working with TREC, the Translating Emergency Knowledge for Kids, in the knowledge translation realm. So I'm wondering if she might be able to comment on how she thinks this approach would translate without us having people on the ground. So hopefully she'll be able to come back. We can save that for me.
I'll keep an eye, Samina.
This is Janet. I'm wondering if you have anything in place so that you can maintain that the evidence is current, or is there someone who will constantly update anything that is identified as something new that can be added to the toolbox?
Absolutely. So this is Taryn speaking. We have it written within the Evidence to Care department to update the schematic review search once a year. We also have a tools to watch section that's outlined in our clinical pediatric chronic pain assessment tool package. So we have kind of our ear to the ground for emerging trends of things that are coming down the pipeline. And in terms of updating the entire package all at once, we'll make sure to stay on par with the clinical practice guidelines from the Registered Nurses Association of Ontario, who we've taken recommendations from to really act as the base for our clinical practice points. So every time that RNAO guideline will be updated, so is our entire toolbox to make sure that we're reflective of the most current evidence available.
Great. And do you have special IT support to upload, or do you do it yourself? Do you make any revisions yourselves to the website?
Yes, we have the power in-house to do those changes on our own, but everything needs to be approved through our communications department.
Great, thanks.
No problem.